Good afternoon. At the outset, I would like to thank Dr. Haldipurkar sir for giving me an opportunity to be a part of this IC. So the correction of presbyopia is usually done with our routine bifocal lenses, and it comes with its own set of problems. The cryptop lens gives more image jump than the D-bifocal, and it has a problem with intermediate vision, so you need to have a less working distance and an uncomfortable head position to work on the computer. So then the progressive additional lenses sort this out to some extent by having intermediate zone between the distance and the near portion. However, the usable field of view is restricted by the eye rotation and the head movement, and the eye rotation causes distortion in the peripheral field that adds to the misery of presbyopia. So there is an opportunity to correct presbyopia during your cataract surgery. So the options would include monovision, wherein one eye is left with a myopia of 1.5 to 2 minus 2 diopters. So, or like you could have a multifocal IOL, or you could have an enhanced depth of field IOLs, and finally you could have a trifocal lenses which has distance, intermediate and near vision. So there are various technologies used in presbyopia correcting IOLs. The refractive technology was used in older multifocals like Resume IOL, but it's no more used. Diffractive technology used widely in trifocal lenses, multifocal lenses, and some of the enhanced depth of field IOLs. And the newer technology is wavefront technology, which uses the principle of altering the spherical aberration across different zones to get a good depth of field. So like if you come to a wavefront technology, here like you have different zones which has either a positive spherical aberration or a negative spherical aberration. Here the central zone has got a positive spherical aberration, and an intermediate zone has a negative spherical aberration. So this gives a good depth of field, so and hence results in a good intermediate vision. This technology is used in mini well lenses, and this gives an extended focus. So there is another technology which is very similar. So here like there is a positive the IOL power increases from periphery to the center gradually. Instead of a zonal change in the spherical aberration, there is a gradual change in the the power from periphery to the center. So this technology is used in newer lens, Technis Eye-Enhanced lens, which also gives a decent intermediate vision. So diffraction is the most popular technology that is used in the multifocal and trifocal IOLs and some enhanced depth of field lenses. So like if you look at the principle of diffraction, when a light passes through the diffraction grating, majority of the light goes undeviated, which is called zero order diffraction, and this is used for distance vision. And another greater proportion of light is deviated by an angle theta, which is called first order diffraction. This is used for near vision, and subsequently smaller amount of light are diffracted, which are second order and third order diffraction, which are deviated by a greater angle. So if you look at the cuneiform optics, the zero order diffraction, which contributes for 40% of the light, is used for distance vision, and another 40% of the light which goes for near vision is due to first order diffraction, and subsequent order of diffraction contributes to lesser amount of light, which of course are not useful for any useful purposes. So there are two methods of producing diffraction. One is stenopic slit and the other is diffraction grating. You can have different types of diffraction gratings based on the blaze angle. That is the angle between the grating surface and the grating step. So something like an eschlet is a special design which is used in symphony lenses. What it does basically is like it deviates more light to the first order diffraction or second order diffraction based on what you want. So that is how it is different. So the symphony lenses give a good intermediate vision because of the elongated depth of field. Now coming to the properties of the diffraction grating, which decides the properties of the IOL, there are two important things. One is step width and the other one is the step height. The step width, the narrower the steps, the higher the additional power. The wider the step, the smaller the additional power. That's how the near add is decided. And the second is the step height, which decides the energy repartition between the far and near vision. The higher the step height, more light goes for distance, and smaller the height, more light goes for distance. This technology is used in apodization, wherein smaller height ridges are there at the periphery and greater heights gratings are present in the center. So the peripheral the peripheral gratings are useful for more distance vision in scotopic scotopic condition. But if you look at the requirement of, there is a requirement for various activities between 40 to 80 centimeters working distance. So the trifocal technology came into existence. Here, like, it depends on two bifocal designs, basically one with a smaller ad, one with a greater ad. When they are placed alternatively, you get a trifocal design. And the final design is the quadrifocal technology or the enlightened technology, which is used in Panoptix trifocal IOL. Here, instead of the three focuses, there are four focuses, that is one for distance 120 centimeters, 60 and 40 centimeters. However, the ridge height of the 120 centimeter focus is reduced to such an extent that most of the energy is transferred to the distance, so it is finally converted into a trifocal IOL. The difference between the classic trifocal and the enlightened technology is that the intermediate power is, in distance is 60 centimeters instead of 80 centimeters. But how do you choose the right presbyopic correcting IOL? So it depends on the patient requirement, patient expectation, and affordability and eye characteristics. So first you need to identify the patient's requirement and expectation before choosing an IOL. So look at his routine activity. How frequently does he read? Does he work on the computer? And his working distance for reading. If he is a myope before, then he has a habitually he habitually works at a closer distance. That you need to know. And then, like, how often does he drive in the after the evening or night driving, and the current refractive status, whether he is myope, hyperope or emmetrope, and does he consider the need for glasses as a failure? Then he is the patient who has a high expectation. And are some halos acceptable? If the halos are not acceptable, any diffractive technology is a no to such patients. So based on the simple requirement, if you want a near vision along with the distance vision, then multifocal is the lens of choice. And if intermediate vision is the requirement, then EDOF lenses or enhanced depth of field lenses are preferred. If both near and intermediate distance is required, then trifocal IOL would be a choice. But things would not be so simple. You should know the patient's expectation before you choose an IOL. Otherwise, unrealistic expectation would lead to a disappointment following cataract surgery. So, if the patient thinks that need for glasses is considered a failure of the procedure, or like he is habitually reads at a closer distance, or he needs to read at a lower illumination, then choose a multifocal with higher ad. And if he frequently drives after it becomes dark, and some degree of halo is considered as unacceptable, then it's better to go with monofocal. However, you can still consider EDOF and apodized multifocals after discussing with the patient. The eye characteristics, basically the pupil size decides. If it's a very small pupil size and the patient has a distance priority, then always go for monofocals. If he has a large pupil and is a distance priority, then go for an apodized multifocal or a trifocal IOL. And if he has got a near priority, then go for multifocal IOL with higher ads. So you also need to look at the visual angles before you choose a multifocal IOL. The angle alpha is the angle between the visual axis and the optical axis, and angle kappa is the angle between the visual axis and the pupillary center. So if somebody has got a large angle alpha, it's better to choose a multifocal, diffractive multifocals or the trifocals, which has got the largest central zone, that is the diameter of the first diffractive zone. So the Panoptix and Symphony has a large central zone, so these should be chosen in patients who have a large angle kappa. And if the patient has a large angle alpha, then it's better to go with a monofocal IOLs. So any patients who has got associated surface disorders, irregular astigmatism, coma, or diabetic retinopathy, or glaucomatous optic glaucomatous optic damage, or age-related macular degeneration, the diffractive multifocals are best avoided. So the two things can destroy any relationship One is unrealistic expectation and the other one is the poor communication. So good communication regarding the nature of the IOL, regarding the glare that you can get with a multifocal IOL, and the halos and the starburst, if you explain it well, most of the problems could be solved. So to conclude, a good communication, good patient selection and good IOL selection would land you in a happy patient. Thank you.
Thank you, Dr. Shetty. I call upon Dr. Suhas Adipukar, one of the finest surgeons in India, to speak on zonules.
Thank you. Thank you, delegates, for staying on. Management